I can quickly introduce the last session of the day. So our session is on non-transplant therapies for marrow failures. And we have outstanding speakers that will discuss some updates on existing therapies for immune marrow failure and some exciting new therapies. And lastly, we have two speakers who will discuss medical therapies for inherited marrow failures. So with that, I'll introduce our first speaker, Phil Scheinberg, who's going to talk about updates on eltrombopag and aplastic anemia.
I didn't do any, okay, good. All right, I knew this was going to happen at the end, being a talk at the end is, anyways, I'll go through this. I have 15 minutes. I'll try to cut it short to 2 or something, 12, okay. All right, so updates, I was asked to talk about updates on aplastic anemia. And basically I'm not going to talk about eltrombopag. You know what eltrombopag is. It's been approved for aplastic anemia second line, front line in many countries, including Brazil. And it has a mechanism of action that we think is stimulating hematopoietic progenitor cells, but it might have other immunomodulatory effects as well, other than just stimulating primitive cells. Now, there's been a lot of publications of eltrombopag and aplastic anemia, which have been published in the British Journal 2 years ago. I'm not going to go through these, but this is just 2021. Most of it started in second line, a lot of it retrospective, some prospective data. And as you go down the table, you see at the bottom, there's been some frontline trials, and I'll focus on the last 2 to 3 years, since the title of the talk was to focus on the updates. So the first update I'm going to talk about is Beneficencia's data, which was published 2 years ago in Blood, looking at the overall survival of patients who were treated with horse ATG, cyclosporin, eltrombopag. And the good news is that most patients are alive, 91%, and of those patients who had a complete and partial response are actually doing very well. Long term, I'm sure there will be updates of this data, especially as it pertains to clonal evolution, which is a major concern that has been discussed at this meeting in the morning and in the afternoon sessions. But we have seen, based on the publication, that the high-risk clonal evolution, which is the one we worry about, has been in the 6% range. So all clonal evolutions that were identified based on cytogenetic abnormalities, regardless of what that was, 14%, 6% actually had high risk, which are the ones you really worry about in terms of clonal evolution, involving chromosome 7, complex cytogenetics, high-risk MDS, and leukemia. Now, obviously, there's been the RACE trial published also in the last 2 years. Now, this is the data coming out of the EBMT, which had the objective to show that horse ATG cyclosporin eltrombopag was better than horse ATG cyclosporin. And the primary endpoint of this study was complete response rate at 3 months, and that was achieved. Group B was the experimental arm, Group A was the control arm, horse ATG cyclosporin alone. And you can see here that the patients who had added eltrombopag to horse ATG cyclosporin did better. And this was published 2 years ago, and it set up a new standard of care. And this was 30 years after the Freekofen published horse ATG versus horse ATG cyclosporin in 1991, and this was in 2021, 30 years later. So that took some time, but we finally got there. Now, if you look at the algorithms, and I'm not going to show, you've seen several algorithms, especially in the afternoon sessions. You're going to see that adults benefit from this triple regimen, or ACE, but the children, it's a little bit uncertain. Now, this was based on subgroup analysis of this prospective large study that was published in the British Journal of Hematology a year or 2 ago, but there's a prospective study that was published in Blood Advances, just looking at the pediatric population out of Russia. And this study actually was advertised as being quote-unquote negative because it did not reach the primary endpoint of the overall response rate at 4 months. Although if you look at the data with a little bit more granularity, you'll see that the complete response rate and the rate of achieving transfusion independence was higher in children who got eltrombopag versus those who did not get eltrombopag. Now, this was about a 100-patient study, 50-50 in each arm, and it was a negative study. Survival looks great, as you expect, in children who are treated with immunosuppressive therapy, 90%, but primary endpoint was not achieved, but complete response rate and achieving transfusion independence was far quicker with having eltrombopag added. So some benefit, but not in terms of overall response. Now, if you look at, again, at one of these algorithms, and everybody mentioned this afternoon, right? Less than 40, transplant, matched sibling donor, and then if you look at the IST, it's horse ATG cyclosporin. Now, the question is, plus eltrombopag, and the question is, what if you have a patient who is not eligible for transplant and they can't have horse ATG, or they can't get horse ATG, or they're not eligible for comorbidities or age or for whatever reason to horse ATG. So they look at this algorithm, a physician look at this algorithm, and they'll see that his patient or her patient is out of an algorithm. They're out of an algorithm. They don't have an algorithm. The patient they have in front of them, 78 years of age, there's no algorithm for this patient. So this is the idea behind this trial that was published a few weeks ago, which started a number of years ago. It started as an investigator-initiated trial, which later on became a sponsored industry trial, but it was started in IIT many years ago. And it was asking the question, could you get away with ATG and just treat patients with eltrombopag and cyclosporin frontline therapy? Now, the primary endpoint was response rate at any time between 0 and 6 months. But there were several secondary endpoints which were looking at response at 3 months, at 6 months, 12 months, et cetera. And this was a single-arm study which included 54 patients. It was an intention-to-treat analysis. And as you can see here, it was a median age of 55. A third of patients had over 65 years of age. So it was an older patient population, and a little bit over 50% had an ECOG of 1. So these were frail, older patients that end up being enrolled in this trial, and that's important because some of these patients actually end up dying early on because of supportive care and logistics and not being able to get all the supportive care they needed based on several reasons, which I'm not going to get into detail here, but just to impress upon you that this is an older cohort. And if you look at the overall response rate on an intention-to-treat analysis was 46%. Now, just keep in mind that there were 4 patients who had a local cytogenetics that was normal, central cytogenetics that was abnormal, and these 4 patients were pulled off the trial, so they never were able to. But they were included as a non-responder as intention-to-treat, so that's part of the 46% overall. The younger patients did better compared to older patients. And if you look at a little bit in terms of subgroups, you'll see less than 65 and older than 65. And you can see that those who are younger than 65 did better compared to the older patient over the age of 65 if they had any response by 3 months or by 6 months or at 6 months. If you look at 60, which was the 65 was actually included in the protocols, the 60 was a bit exploratory, you'll see the same trend that younger patients tend to do better with a combination of eltrombopag cyclosporin. The cyclosporin was given with routinely with 200 to 400 micrograms per liter in terms of a serum level, and eltrombopag was 150 once a day. Now, this is another exploratory endpoint, but the question was, of those patients who completed 6 months, obviously everybody who died, everybody who had these cytogenetic abnormalities or other reasons who did not complete 6 months were counted as non-responders, intention to treat. But what of those who completed? There was 35 patients actually who completed the 6 months, and you can see here that of those patients who actually made it to the 6 months, even being older and having comorbidities with an ECOG of 1, et cetera, the response rates actually look a little bit better. They're not going to be as good as an older patient who got horse ATG cyclosporin. And remember, horse ATG is not widely available in many markets, many countries in the world. They're starting to relaunch it in several places, but they're not available still. So a lot of centers still use rabbit ATG. But of those patients who actually complete the 6-month period, the response rates look a little bit better. This is a swimmer's plot looking at transfusion independence and time to transfusion. And the important thing of this slide is that even among the non-responders, about 48% actually was able to spread the transfusion intervals, which I think is a good outcome if you're a non-responder with this disease. So there's some benefit in this patient, although they were counted as non-responders because they didn't meet criteria. Very well tolerated agent. No drug, no fatal or high-grade SAE that was attributed to therapy. Most patients had complications due to their underlying disease, aplastic anemia. So this combination actually turned out to be effective, safe, but not as good as an older patient who can be treated or was treated with ORCTG based on HIG's EBMT data, that if an older patient can get ATG, they should get ATG. And there's a manuscript actually under revision that's also sending the same message, which should be coming out for publication in the next couple of weeks. Now, most patients are younger in this patient population. There's a bimodal distribution, we know that, and there's a few patients who are older. But is that true? So what I'm going to show you is a work in progress. Last 2 minutes, it's not going to be, we actually have been involved in an analysis which includes companies that are experts in looking at large data sets and trying to understand what's happening to a specific patient population. And I've been involved with this project for most of last year, and this is ongoing work. 330 million patients in the United States. This is only based in the United States from 2017 to 2023. This is based on claims. There are billions of claims that are made in the United States, billions. I mean, it's amazing the amount of data that this group actually was able to work. And the idea here was to find out how many patients of all the claims in the United States from this 6-7 year period eventually had the diagnosis of aplastic anemia. Very complicated, very comprehensive, very rigorous, very filtered type of data. But to make a long story short, everything was included that could potentially be associated with aplastic anemia. There was a huge algorithm and process by which this data was run through based on very rigorous criteria, and we participated in helping the people working with the methodology and the computational biology and AI, et cetera, to come down to the 1937 patients who actually ultimately were diagnosed in a 7-year period with aplastic anemia in the United States. I don't have time to go through all the process, but there's over 150 slides of this data set. I just chose 4 or 5 to show them to you. But what I was surprised when I saw this is that if you look at the age distribution, there's probably a larger population of older patients that are eventually diagnosed with aplastic anemia than we previously estimated. There's problems with these type of analysis, but this number actually was consistent throughout. And if you look at the incidence on the top right, we're hitting between 1 and 2 per million, which is kind of right. And there's several other pieces of data that I won't have time to show that really shows that this data set actually is pretty accurate in terms of what other diseases were associated with aplastic anemia and what other conditions were not associated with aplastic anemia, things that we know already. And you can see here a Kaplan-Meier curve for these almost 2,000 patients diagnosed through a 7-year period, showing that older patients don't do as well compared to younger patients. So I thought this was interesting to show. And just to conclude, you can see that there's the claims data about 100, 150 days before a diagnosis is made, talking about early detection and early therapy for patients, especially older patients who might have this diagnosis. You can see that the curve starts shooting up, and a median of 90 days was the time to diagnose a patient with aplastic anemia based on this large database and data set of claims data in the United States. And you can see as you approximate the diagnosis, the claims start shooting up, and there's all kinds of claims actually that end up being included in this type of analysis. And there's AI and computational stuff being done and has separated the history of this patient into 4 groups that differ by time to diagnosis, time to therapy, and we're looking at these different groups. So eltrombopag cyclosporin, although we thought that would be benefiting at least a small group of people, it might actually be applied to a larger cohort of patients than we anticipate. And we suspect that there's all kinds of biases in which can contribute to this type of observation, because older patients don't get referred to tertiary centers, they don't get put into protocols, they're never counted, basically. That's one explanation, but there's several others that you can come up with. So this is just a graphical representation of these 4 groups of patients that have been identified in this analysis. To conclude, there's been recently the advances in the field with eltrombopag has been the RAISE trial, has been this SOAR trial, the eltrombopag cyclosporin, And I think the next speaker will talk about TPO agonists other than the eltrombopag, I think romiplostim. So, Beneficencia, I was below my 15 minutes. I spoke quickly, but I think I was able to convey the major messages here. Thank you very much.
That was wonderful. As Phil said, to continue the discussion of TPO agonists, we're going to have Kinuko Mitani from the University of Tokyo, who's joining us virtually to talk about recent studies looking at the effects of romiplostim in aplastic anemia.
Thank you very much. Just a moment. But I can't present my PowerPoint. It said host. Just a moment. Okay. A kind of introduction. The title of my talk today is Efficacy and Safety of ATG plus SIA plus romiplostim for untreated aplastic anemia, phase 1, 2, 3 trial. This is my COI disclosure. Romiplostim, a TPO mimetic protein, has been shown to promote lineage hematopoiesis in patients with acquired aplastic anemia refractory to immunosuppressive therapy or eltrombopag. However, its effectiveness in combination therapy with anti-thymoglobulin plus cyclosporin A as the first-line treatment remains unknown. This study was conducted in Japan, Korea, and Taiwan to evaluate the efficacy and safety of romiplostim in patients with aplastic anemia who were previously untreated with IST. This is study design. Rabbit ATG was administered from day 1 to 5, cyclosporin from day 1 to week 52, every day orally, and romiplostim from day 1 to week 26, once a day subcutaneously. The initial dose of romiplostim was 10 microgram per kilogram. After week 5, the dose of romiplostim could be titrated stepwise up to 20 microgram per kilogram, depending on the platelet response. The original protocol lasted until week 30, but at the end of the study visit, patients who were determined by investigators to need to continue administration can be treated for up to 52 weeks. This slide shows key eligible criteria and endpoint. Eligible patients are those who were diagnosed as aplastic anemia and were considered to require new treatment with rabbit ATG and cyclosporin A. Non-severe patients must be platelet or erythrocyte transfusion dependent. Patients aged 20 years or older were enrolled in Japan and Taiwan, and those aged 19 years or older in South Korea at the time of consent. ECOG performance status score should be 0 to 1 at screening. Their primary and secondary endpoints. Primary endpoint was achievement of CR or PR at week 27. Secondary endpoint included achievement of CR or PR at week 14, the time to CR or PR at each evaluation time point, decrease in platelet or erythrocyte transfusion requirement, and oral transfusion independence at week 27. Changes from baseline in platelet count, hemoglobin concentration, neutrophil count, and reticulocyte count at each evaluation time point until week 27, and safety. This slide shows patient disposition. 25 patients were screened and 17 patients were enrolled and received romiplostim. Among the enrolled patients, 971 were from Japan, Korea, and Taiwan, respectively. The enrolled period was from June in 2019 to May in 2020. Until week 27, 2 patients discontinued the study, one because of safety and the other wished to withdraw the consent. And 15 patients completed the study protocol. Among 50 patients, 11 patients entered the extension phase, and all the patients completed the protocol at week 52. This slide shows patient characteristics. The median age was 44 years old, with maximum age being 70. Female ratio was 53%, and the median time since diagnosis was 15 days. The number of non-severe, severe, and very severe patients were 5, 6, 6, respectively. Median platelet, neutrophil, reticulocyte counts were 12,340,000 per milliliter. As I told, primary endpoint was achievement of CR or PR at week 27. The criteria is described below. Patients were judged in CR when all the following criteria were fulfilled, namely hemoglobin concentration equal more than 10 grams per deciliter, neutrophil count equal more than 1,000 per microliter, platelet count equal more than 100,000 per microliter. Patients with severe and very severe disease were judged in PR when they became transfusion independent, and the criteria for severe diseases were not fulfilled. On the other hand, PR patient with non-severe disease requiring transfusion at baseline judged in PR when they became transfusion independent. This slide shows a response rate by severity subgroup. The rate of PR and CR at week 27, the primary endpoint was 76.5% in the total population and 75% in very severe plus severe subgroup and 80% in non-severe subgroup. It is difficult to statistically compare the result between very severe plus severe group and non-severe group, but treatment with romiplostim appeared more effective in non-severe subgroup. This slide shows time to achievement of the first hematological response until week 27. 13 patients achieved PR or PR until week 27. The median time to the first PR or CR was 93 days, with minimum time being 63 days and maximum time being 181 days. This slide shows a decrease or independence of transfusion at week 27. Regarding platelet transfusion, 16 patients were platelet transfusion dependent at baseline, and at week 27, 40 patients showed a decrease of platelet transfusion, and 12 patients became transfusion independent. On the other hand, regarding RBC transfusion, 16 patients were transfusion dependent at baseline, and 13 patients achieved decrease of transfusion, and 12 patients became transfusion independent. Therefore, by the treatment with romiplostim, 3/4 of patients became transfusion independent in both erythrocyte and platelet. This slide shows changes in hematological parameters with romiplostim treatment. Neutrophil count increased in the initial phase of the treatment, while platelet count and reticulocyte count began to increase associated with the dose increase of romiplostim. Hemoglobin concentration gradually increased until week 27. In every lineage of blood cells, the increased levels were maintained until week 27. This slide shows a summary of treatment emergent adverse event, TEAEs. All the patients experienced some TEAE, but patients with drug-related TEAEs accounted for 29%. Neither a drug-related severe adverse event nor drug-related TEAE leading to death or treatment discontinuation was observed. On the right, a breakdown of drug-related TEAE are shown. Some abnormalities in laboratory data, such as gamma GTP, were observed at a frequency from 6% to 12%, but all the events belonged grade 1-2, and there was no event more than grade 3. This slide shows a result of bone marrow examination. None of the patients showed abnormalities in karyotype after receiving romiplostim treatment. None of the 17 patients enrolled showed a transformation to AML and MDS during the study. This is the conclusion. This study is the first clinical trial of romiplostim combined with Rabbit-ATG plus cyclosporine A in patients with acquired aplastic anemia requiring transfusions who were previously untreated with IST. This regimen produced a higher hematological response rate at week 27, 76.5%, compared to that of historical controls who received Rabbit-ATG plus IA approximately 50% at 6 months with manageable adverse event. Therefore, IST plus romiplostim could serve as the new first-line treatment option for patients with aplastic anemia. Thank you for your attention.
Thank you, Dr. Mitani. If you could just stay on, we're going to take questions at the end of the session. So can I will like to introduce Dr. Joseph Oved, who will discuss now Emapalumab in pediatric aplastic anemia patients.
All right. Thank you, Tim and Bhavisha, for inviting me to speak. And I'm going to talk about our newly opened investigator-initiated phase 2 trial called Emapalumab, a window of opportunity in pediatric aplastic anemia. And so everyone in the audience knows what acquired aplastic anemia is. So it is a T-cell mediated disorder that is caused by an exposure to some sort of antigen that can trigger an autoimmune T-cell response in a susceptible individual. The T-cells activate, expand, and migrate to the bone marrow and cause hematopoietic stem cell death, either directly through the T-cells or by the cytokine milieu that is secreted by the cells. Speaking about algorithms, here it is again. So you have a patient under 40 with a suspected aplastic anemia diagnosis. And for the first 6 weeks or so, and we talked about this earlier today, they get a workup. And during that time, they only get supportive care sometimes as they're getting sicker, sometimes as they're stable, but they're sitting there for some amount of time while we do molecular testing and while we do genetic testing if it's clinically indicated. If they wind up having an HLA identical sibling, they can go to transplant. It accounts for about a quarter of our patients. If they don't, they get immune suppression therapy with horse ATG and cyclosporin. If they have count recovery and no clonal evolution, we wean the IST and observe. If not, we can consider salvage with an alternative donor transplant. So these are the curves for IST that we've all seen, the European experience over here, the North American experience over here. And the difference, again, we've talked about is the rabbit ATG versus the horse ATG. So the European experience is a 3-year overall survival of 87% and an event-free survival of 33%. The North American experience, a 5-year overall survival of 92% and a 5-year event-free survival of 62%. Notably, in this pediatric cohort, the clonal complications were found to be about 2 to 7% over the study, which is lower than what is found in the adult cohort. We talked a little bit about the addition of eltrombopag to IST, and over here you can see in the adult population that triple IST has improved outcomes, so the overall response and complete response are listed with IST over. This is not working. Okay. So are listed over there, 66% and 10% versus triple IST of 94% and 58% respectively. In pediatrics, unfortunately, we're still sussing out if the addition of eltrombopag is going to have any effect or not. And so the question has arisen in the pediatric field of whether or not unrelated donor transplant should be considered as an upfront option, and we've heard a little bit about that as well. Though some of the concerns that we talked about in the previous session were exposure to alkylator and or TBI, the fertility risks with TBI 400, graft rejection, and GVHD risks. And so we wanted to counter with a different way of thinking about this and say, instead of concentrating on donor type and asking if transplant should be moved up front for all patients, can we learn from the rest of HEMONC where they can stratify cancers by high risk and low risk, and stratify patients with aplastic anemia as high risk of not responding to IST versus low risk of not responding to IST, and decide based on the patient-specific characteristics who should get upfront IST and who should get upfront transplant. And this question arose from a retrospective analysis we did at a single center of 85 pediatric patients with aplastic anemia, 52 of which had received upfront IST. We did a comprehensive analysis for clonal hematopoiesis, including PNH, HLA loss, both through inactivating somatic mutations and 6-PLOH, as well as somatic changes in malignancy-associated genes. And what we found here was that if a patient had either a high-risk HLA-A or B allele that was previously defined and published by Dasha Babushak's group, and or they had a somatic clone that was present, their event-free survival at a minimum of 2 years after IST was a mere 32.4%. However, if they had none of these clonal changes present, then their event-free survival at a minimum of 2 years after IST was 83%. And so I would counter that this represents a population of patients that might benefit from upfront IST rather than upfront intensification of therapy. However, the problem is that some of these clonal analyses that we did take quite a bit of time, specifically the HLA inactivating somatic mutations, and are not amenable to the clinical workflow. Otherwise, you'd have patients sitting for 4 months, which, as we discussed earlier, we don't want. And so we had to think of another way of how we can potentially stratify these patients to those that might respond to IST better than others. And so we turned back to the pathophysiology of aplastic anemia and went all the way back to when I was still a toddler. And in this paper over here, Joe Laver and Richard O'Reilly at MSK showed that when they took T cells from patients with aplastic anemia and they co-cultured them with hematopoietic stem cells, those T cells were able to abrogate the ability of the hematopoietic stem cells to form colony-forming units. They were able to rescue the phenotype of the hematopoietic stem cells by adding an anti-interferon gamma antibody into the culture. And they were also able to show rescue of the hematopoietic stem cells when they used T cells that were from patients treated with IST rather than pre-treated patients' T cells. Then they took the same T cells from patients, cultured them, took the supernatant from the T cells, and cultured them with the hematopoietic stem cells. The hematopoietic stem cells were unable to form their colony-forming units, and they were again able to rescue with the anti-interferon gamma antibody. And so they were able to show that this was a soluble mediator, likely interferon gamma, that was causing a lot of the distress for the hematopoietic stem cells. Fast forward a couple of decades, and Carlo's lab had shown that T cells that were infiltrating the bone marrow of patients with acquired aplastic anemia had higher levels of expression of interferon gamma and TNF alpha in both the CD4 and CD8 compartment. And then interestingly, this paper came out at around the same time where patients that actually were found to be responders of IST were those patients that had significantly higher interferon gamma marker expression in their T cells, both in the CD4 and CD8 compartments, compared to the patients that didn't respond to IST, which was similar to the healthy controls. Further evidence for interferon gamma, again from Carlo, was that the polymorphisms that lead to overproduction of interferon gamma and the interferon gamma gene are significantly enriched in patients with aplastic anemia and are a risk factor in the Caucasian population. And then we found that somatic variants and somatic mutations in the JAK-STAT pathway, which again is part of the interferon gamma pathway, are much more prevalent in patients with aplastic anemia. And so what you can see here are all of the different somatic JAK-STAT mutations that occurred in aplastic anemia patients, and 75% of the patients in this cohort were found to have a somatic variant accumulation in the JAK-STAT pathway gene, either in the CD4 or CD8 T cells, which was compared to 40% in age-matched controls. Thinking about eltrombopag, this is less clearly defined, but one hypothesis is that it partly works by circumventing interferon gammas. Steric hindrance of c-MIPL. So what you can see here is that TPO, as we all know, binds c-MIPL and promotes a survival signal for hematopoietic stem cells. When there is high circulating free interferon gamma, it can dimerize with TPO and cause steric hindrance, abrogating the survival signal and causing hematopoietic stem cell senescence. Eltrombopag binds at a different location of c-MIPL and does not dimerize even in the setting of high interferon gamma, thereby restoring that survival signal for hematopoietic stem cells. We saw this earlier this morning as well, so the single agent JAK inhibition that resolved aplastic anemia in a young adult. And so this was one center that used a JAK1 specific inhibitor, itacitinib, for severe aplastic anemia in the setting of a STAT1 gain of function, which causes constitutive interferon gamma production with complete resolution. When they looked back at their last 9 patients, 6 of the 9 had STAT1 hyperactivation. Other centers have now started reporting the enrichment of STAT1 gain of function, STAT1 hyperactivation in their aplastic anemia cohorts, as well as SOX1 haploinsufficiency, which would cause the same overproduction of interferon gamma. Lastly, Emma Groark and her group in a tour de force showed the effects of JAK1/2 inhibition with ruxolitinib, used either in a therapeutic or prophylactic manner in their murine model of aplastic anemia. And when they gave ruxolitinib to the mice and induced aplastic anemia, you can see the survival benefit over here that was significantly better than mice that did not receive ruxolitinib. They rescued the ability of the stem cells from the mice to form colony-forming units. You can see the decrease in interferon gamma and in TNF alpha, and you can see the difference in the marrows, which is pretty significant. And so we've built the case that interferon gamma is somewhat involved in acquired aplastic anemia. And so the question now is, how can we leverage that? And so we heard that the NHLBI has the ruxolitinib trial coming out in relapsed refractory setting. And so we wanted to ask the question of, can we use an early upfront interferon gamma blockade to stratify the patients? Can we say this patient is a high-risk patient, this patient is a low-risk patient, by using upfront gamma blockade and decide which patients are going to go to IST versus transplant? And so the way we set up the trial is we chose to use Emapalumab because it doesn't have the cytopenias that are associated with ruxolitinib. And so this is set up as a patient comes in with suspected aplastic anemia. They get their bone marrow and aspirated biopsy. You rule out leukemia within the first 24 hours, and you start Emapalumab right away without waiting for any other test results. The hope is to start it within 24 hours, but you can start it anywhere within the first week. And you get 6 weeks of Emapalumab weekly dosing. During that 6 weeks is the time that you're doing your standard aplastic anemia workup. And at the end of 6 weeks, you get a response evaluation, which I'll show you on the next slide. Patients that are deemed responders to interferon gamma blockade are those that are likely going to respond to further immune modulation, and so they would go and get consolidated with immune suppression therapy augmented with additional Emapalumab. Those that are not responders are going to go to institutional standard of care, and just given how many different ideas there were about what transplant should look like, we are going to leave it at institutional standard of care and not get stuck in that quagmire. It's set up as a phase 2A, 2B. Trial phase 2A is to evaluate if our response criteria are appropriate, if they're capturing the right patients. We have an interim analysis at 10 patients, and any patient that meets this response criteria, however, will automatically get rolled into phase 2B. Phase 2B is to evaluate the response of IST to the patients that had the initial hematologic response to Emapalumab. So what did we consider a hematologic response? And we spent a lot of time trying to figure out response criteria that were sufficient to show an actual response, but not too high a bar so that there wasn't, we weren't screening out patients that otherwise would be amenable to IST. And so this is what we came up with. Essentially, we want to bump patients out of whatever category of aplastic anemia they have into the next category. So if you had very severe acquired aplastic anemia, you needed to have an ANC greater than 200 times 2 counts within 7 days. But it also must be 2 times whatever your initial ANC was at diagnosis. So if you had an ANC of 150, 300 would be your minimum necessary number for response, just because an ANC of 150 and 200 is a little too similar. In severe aplastic anemia, you'd need to meet 2 of the following criteria. For your ANC, it's a similar story. ANC has to be greater than or equal to 500 times 2 within 7 days. With at least an increase of 200 from diagnosis. Again, if your ANC was 450 at diagnosis, you'd have to have a 650 to be considered a responder there. Platelet count of at least an increase of 10,000 from diagnosis in the absence of transfusion times 7 days, or a stable platelet count for 2 weeks without transfusion if you were previously requiring transfusion, or an absolute reticulocyte count of an increase of 10,000 from diagnosis for 7 days. And so what does this look like? This is designed as a 10-institution study, designed in 2 stages with a total of 52 patients that we need to be treated on the IST arm that have previously responded to EMA. The primary objective over here is to increase response to IST from 60% to 80% in those responders. The key secondary objectives are to assess if early immune modulation decreases clonal hematopoiesis, mostly by preserving a larger reservoir of hematopoietic stem cells. We're going to prospectively validate the clonal hematopoiesis markers that I mentioned previously, and we're going to evaluate the effect of Emapalumab on patients that go to transplant or to institutional standard of care, again with the thought that maybe given the data behind Emapalumab and graft rejection, that this actually might be a nice way to abrogate the need for TBI in these patients. Additional secondary endpoints that we are looking at, we are going to build a horse ETG PK model, and this is derived from the data that we have in transplant with rabbit ATG, where we show that all patients that get standard weight-based dosing of rabbit ATG have very, very different exposure levels. So some patients that got standard weight-based dosing have 5 to 7 days of lympholytic levels of ATG exposure, while other patients have 60 or 70 days. So there's a huge variety in your exposure with standard weight-based dosing, and we expect to find the same in horse ATG. And so would this actually cause patients to have a better response if they're getting the minimum necessary horse ATG exposure? We're building out an Emapalumab PK model. We have At MSK, we've built out a PK assay for Emapalumab, so we'll build that out as well while we're doing this. And obviously, we're asking if Emapalumab is going to help us stratify the risk. And we're also asking the question if early immune modulation will decrease the eventual clonal hematopoiesis that we've seen. And so with that, I'll conclude that the JAK-STAT pathway, and particularly interferon gamma, represent very rational targets for therapeutic interventions in patients with aplastic anemia. We are testing if early upfront immune blockade may preserve a larger pool of hematopoietic stem cells and prevent additional clonal hematopoiesis from occurring while increasing IST response rates. This is the first time we're going to prospectively try to validate our clonal hematopoiesis markers that we previously analyzed. The development of a horse ATG PK model will be important to evaluate if a minimum exposure to horse ATG is required for actual adequate response to IST. And we have a robust sample collection to identify cellular and soluble biomarkers that can help tailor our personalized platform further. And I'll mention that the trial is currently open at MSK. If anyone wants to refer a patient, we'd be happy to screen them. And with that, I will acknowledge our MSK transplant team, our lab, as well as the trial sites that are getting up and running. I'd also like to thank Sobi for providing us with drug and some funding, as well as some of our funders. And hopefully we'll have results to report soon. Thank you.
That was great. Thank you very much. All right. Along the same vein, in the JAK-STAT pathway, we're going to talk a little bit about JAK inhibitors in marrow failure, and I think Jibran Durrani is going to give this presentation.
Good evening. My name is Jibran Durrani. I'm a fellow at the NHLBI. I would like to start off by thanking the organizers for the opportunity to let us share our experience with JAK inhibitors. I do not have any conflict of interest to declare. As I go through this talk today, I will share with you why we are so excited about the use of JAK inhibitors in immune bone marrow failure disorders. Immune bone marrow failure disorders are a heterogeneous group and can cause single or multi-lineage cytopenias of varying severity. They exist on a spectrum with many overlapping features. Aplastic is the prototypic bone marrow failure disorder. And while the degree of aberrancy may differ, many of the inflammatory pathways are shared between these diseases. Availability of standard treatment options are limited, and relapses are often high. The pathophysiology of aplastic anemia is an immune-mediated attack by activated cytotoxic CD8 T cells, inflammatory cytokines, TNF-alpha, interferon gamma, as well as an upregulation in JAK-STAT activity. With the addition of eltrombopag, responses to first-line treatments have shown a remarkable improvement. However, relapse remains a major issue. And even in patients treated with on our most recent trial at the NIH, we have seen this to be comparable to our historical immunosuppressive therapy group. Treatment options in the second line are limited, with the preferred treatment to be transplant for those that are fit. Those that are either unfit or do not prefer to get transplanted, we can offer a pharmacological intervention. However, overall response rates are low, between 30 to 60%. With that in mind, we wanted to explore honing into a JAK-STAT pathway as well. Others have shown that the use of JAK inhibitors in immune-mediated disorders has shown some results, actually good results, GVHD, HLH, DLGL. The JAK are cytokine that are cytoplasmic tyrosine kinases. They link cytokine signaling from membrane receptor to STAT transcription, and they play their pivotal role by modulating immune fitness, inflammation, tissue repair, and hematopoiesis. And as you can see over here, that this is a very complex system. And by activation in pairs, it produces a variety of regulatory responses. So we wanted to test our hypothesis, and we tested this in our murine model of immune-mediated bone marrow failure. We have previously modeled human aplastic anemia by adaptation of Run disease, in which infusion of donor lymph node cells into recipient mice after sublethal irradiation consistently induced severe pancytopenia and bone marrow destruction in recipient mice compared to normal mice or irradiated-only mice. We also observed infiltration of T cells, as well as an accumulation of fat cells over time, which highly mimics human aplastic anemia. So we tested ruxolitinib, and we saw that it attenuated bone marrow hypoplasia, ameliorated peripheral blood counts, and preserved hematopoietic progenitors, as well as improving overall survival. It also suppressed the infiltration, proliferation, and activation of affected T cells, as well as mitigating fast-mediated apoptotic destruction of target hematopoietic cells. And as you can see on this cytokine panel over here, that the mice treated with the ruxolitinib showed a decrease in interferon gamma, TNF alpha, as well as some of the pertinent interleukin involved in the pathophysiology of aplastic anemia. Our hypothesis was further corroborated by the RNA sequencing data, and as you can see on the heat map on the left, that the pathways involved with the inflammation are downregulated, including STAT1 and STAT3 and interferon gamma. And the swimmer's plot on the right shows similar data, with the immunity being downregulated, TYK2, Janus kinase being downregulated. We next wanted to see how late we could treat the mice and still effectively rescue the blood counts. And when we introduced ruxolitinib at day 4 and day 6, compared to the bone marrow failure mouse model, we saw that we still were able to achieve 100% survival. And this was interesting because in the past we had tested this strategy with ATG, with delayed treatment, and saw that over time the efficacy declined. So this work resulted in the conception and now accrual, open for accrual, phase 1, phase 2 study of ruxolitinib for relapsed refractory immune bone marrow failure. These are our endpoints. Primary endpoints are safety and efficacy. And this is the study design. As you can see, we have 5 arms, and each of these individual arms will accrue initially 10 patients. If we see a response in 2 or more patients, we can accrue another 19 patients onto the arm to get to a total of 29. Each of these arms is independent of each other. This is the treatment schema. Responses will be assessed at 3 months and 6 months, and thereafter every year. Treatment will be concluded at a maximum of 6 months. If there is a complete response, we'll stop treatment at 3 months. At this time, I have to also add that there will be weekly labs done to assess for hematological toxicities. And currently, we've accrued 3 patients. The first patient accrued onto the trial has achieved the maximum dose of 20 milligrams twice a day without any signs of hematological toxicity. So as exciting as this was, we also realized that we had 2 more questions that we felt needed to be answered. Do all JAK inhibitors perform similarly? And could a systematic blockade of specific JAK-STAT pathways teach us more of their role in immune modulation? So we then systematically blockade different pathways and observed the effects on our mouse model. We first chose to test baricitinib, which is a JAK1, JAK2, and a TYK2 inhibitor. It spares JAK3. And as you can see over here, that we were able to mimic the results from our original ruxolitinib trial, actually experiment, and we saw that there was an improvement in all blood counts, as well as an improvement in the total bone marrow cells. We also noticed an improvement in the CD4 counts and a downregulation of infiltration of CD8 cells. This is the overall survival curve showing an improvement. Next, we tested tofacitinib. Tofacitinib is a JAK1 and 2 and 3 with a more intense inhibition of JAK3. It spares TYK2. And interestingly over here, the drug was unable to elicit the same response. We saw an improvement in RBCs and platelets, but not in the bone marrow cells. Also, it did not reduce the infiltration of the CD8 cells or show a significant improvement in survival. Interestingly, if you notice over here that initially we saw that the overall survival was improved, but around day 30 of the experiments, there was a rapid mouse death. We also tested very selective JAK inhibitors, fedratinib, which is a JAK2 inhibitor, and solcitinib, which is a selective JAK1 inhibitor. And again, we were unable to show an improvement in the peripheral counts on bone marrow cells. We did not see an improvement in the infiltrated CD8 cells, and the overall survival was not much different from our mouse model for bone marrow failure. So this was all done to show if, or to test if all JAK inhibitors would work equally and equally effectively. And we compared to ruxolitinib, we know that baricitinib, which is a JAK1, JAK2, and a TYK2 inhibitor, produces comparable results. Tofacitinib, the more potent inhibitor of JAK3 versus JAK1 and JAK2, showed suboptimal improvement, and very selective inhibitors, either of JAK1 or JAK2 alone, failed to show improvement. So currently our data suggests that a strong inhibition of JAK1 and JAK2 combined is what is probably required to attain the desired results. Next, as an alternative treatment strategy, we tested subtherapeutic doses of cyclosporin and ruxolitinib as a strategy to evade risk of myelosuppression with prolonged exposure to JAK inhibitors, and noted an improvement in platelets and neutrophils. And as you can see over here, that the combined strategy also resulted in improved overall survival versus when either of the therapy was used as a monotherapy. So the future direction for us in the preclinical setting is that we want to test systematically block specific JAK-STAT pathways to study recovery in immune murine model, elucidate pathways most relevant to immune bone marrow failure disorders, and to investigate alternative JAK inhibitor options in the event of intolerance or toxicity to ruxolitinib. On the clinical side, our goal is to complete our current clinical trial in relapsed refractory immune bone marrow failure. And if given that JAK inhibitors are an oral alternative, if we see success, we would test this in the upfront first-line setting. With that, I conclude my talk and would like to thank my mentors, Dr. Emma Gwarg, Dr. Bhavishya Patel, Dr. Neil Young, are my lab collaborators, Dr. Feng and Dr. Chen, for their support and guidance, and the NIH Intramural Research Program for its funding support.
Thank you, Dr. Durrani. And Dr. Olson actually has to get to another meeting, so he'll.
I'm the worst moderator award. I apologize.
I would like to welcome Dr. Andre Larochelle, who will discuss his ongoing work on medical therapies in Fanconi anemia.
Great. Thank you, Babish. When I realized the time at which I'd be speaking today, I didn't take a chance, and I got myself a bottle of 5-hour energy, which works really well. So if I still talk in 5 hours, make sure you stop me, all right? So, all right, I think, so I'll focus on Fanconi anemia today, and let me skip the intro. I think this crowd does not need an introduction on Fanconi anemia. This is, suffice to say that the primary treatments for progressive cytopenias in patients with Fanconi anemia consist primarily of the use of androgen, and the only curative treatment right now is allogeneic stem cell transplant. Both, as we well know, are associated with significant toxicities, even though they can be very efficacious. Gene therapy are also in development, but quite limited, as we all know, given the very low number of cells within the marrow in these patients. So that's why we've taken a slightly different approach, and we've decided to test eltrombopag as a potential alternative treatment for marrow failure in these patients. Again, EPAG, which I'll refer to as, does not need an introduction to this crowd, but enough to say that both, it's a small molecule mimetics of TPO, and both TPO and EPAG, as a reminder, work through the CMIPL receptor in HSPCs. So the question is why? Why EPAG in Fanconi anemia marrow failure? So we propose that eltrombopag works by improving both the DNA repair and also by evading inflammatory hypersensitivity in HSPCs and Fanconi anemia. So in more detail, when, for example, during normal metabolism or in response to environmental factors, species such as ROS or aldehyde accumulate and can lead to formation of ICLs and interstrand cross-links. So in the absence of a functional Fanconi pathway, these ICLs may not get resolved, leading to a stalling of the DNA replication fork and eventual accumulation of double-strand breaks, which I'll refer to as DSB. So in Fanconi anemia, the homology-directed repair pathway is not functional. So most DSB are repaired via the classic non-homologous enjoining pathway, which is viewed as a high-fidelity pathway leading to cell survival and genomic stability. So key to our model is the established now function of TPO in the regulation of this classic non-homologous enjoining pathway. Should this pathway fail, double-strand breaks may be left unrepaired, resulting in cell death and bone marrow failure. Or alternatively, they may get repaired via the risky alternative non-homologous enjoining pathway that can lead eventually to malignant transformation. So as was alluded in the previous talk, so first, pro-inflammatory cytokines are also known to be involved in the pathogenesis of Fanconi anemia, thought to be released by a stressed marrow, failing marrow. So we previously shown that TPO function is inhibited by pro-inflammatory cytokines, primarily interferon gamma, via protein-protein dimer formation, which prevents TPO from binding to its receptor CMIPL. So this inhibition can block the classical non-homologous enjoining pathway, increasing reliance on the other less desirable outcomes shown before. In contrast to TPO, EPAG can evade this inflammatory inhibition by avoiding capture by interferon gamma, allowing DNA repair to occur via the classical non-homologous enjoining pathway and decreasing reliance on these other less desirable outcomes. So that's the main idea, and those preclinical data, along with the well-established now function of eltrombopag in other bone marrow failure, namely immunoaplastic anemia, gave us the idea that this drug might be of interest to treat marrow failure in Fanconi anemia. So to test this hypothesis, we've established this clinical trial, which is simple, really. So eligible patients take EPAG only, orally, once daily. And the endpoints are measured at 6 months. The primary endpoints are both efficacy and safety. Hematologic response is measured if there is at least a minimum improvement in the marrow cellularity by twofold, or a marrow increase in CD34 percentages by at least twofold, or a peripheral blood response, which is marked by improved counts in at least one lineage, and we also have a few secondary endpoints. So patients that do not respond at 6 months are taken off study, whereas those that do respond are invited to continue on the extended phase of the study, which is another 3 years, for a potential total of 3.5 or 42 months. So we've enrolled to date 20 patients. 17 of them have reached the 6-month endpoint, and I'll present our interim data on these 17 patients. As you can see, highlighted in red in this table, most are children with a single adult patient. Most are Fanconi anemia A, the most common complementation group. and all add some evidence of dysfunction in all three lineages. So we have, at this point, already met our primary endpoints based on marrow response, peripheral blood response, as well as safety. So looking at the marrow response, we've seen a response in 15 out of 17, or 88%, and we see a representative marrow here from patient 2 at baseline and 6 months, showing a 4-fold increase in marrow cellularity. We also assess marrow response based on flow by an increased percentage in CD34 cells, and again, this is a representative marrow or flow on patient 2, showing an increase in CD34 positive cells by 3-fold at 6 months. So when considering both cellularity and 34 positive cells, we've observed at least 5-fold increase in CD34 positive cell counts at 6 months in approximately half of our cohort. At a later time point, which varies between 7 and 42 months, with a mean of approximately 19.5 months, the overall increase in CD34 cells averages at 14-fold, which I think is significant considering our interest in expanding the eligibility of patients with Fanconi anemia for gene therapy among patients who are or were previously deemed unsuitable for this treatment due to insufficient cell numbers. Looking at the peripheral blood response, we see a response in 11 of 17 patients, or 65% of them. Most of them actually achieve an erythroid response. And we have, let's see if I can, so the issue at 6 months, as you can see, is that we have very few patients achieving a robust trilineage response. And this is quite in contrast to what we see at a later time point, where this response increases from 9% to 55%. The message being that it takes time for this drug to act, likely due to its function in the most primitive and dormant hematopoietic stem cell compartment. So looking at the peripheral blood and the longitudinal blood improvement over time, the graph on the right shows the erythroid response in our patients. Each line represents one patient over time. So we see a response in 9 of 11 patients, so 82% of them, and that increases up to 91% at the latest evaluation. One patient of particular interest to me is the one shown in the, I think it looks like an orange line here, where she started at a baseline hemoglobin of 4.5, obviously heavily transfusion dependent. Eventually reached transfusion independence at the time point of about 9 months. And at her latest evaluation a few weeks ago, her hemoglobin was 13.1, so very essentially normal. And you should have seen her face when I told her that her hemoglobin is now higher than mine. So she was pretty excited. She wants to be a doctor, so maybe she'll prescribe eltrombopag to me in the future. Who knows? But clearly, the erythroid response is the most common and the most robust and the fastest of all. Platelet response, as you can see, was less robust, but yet eventually achieved levels between 60 and 150 at the latest time point. The overall response was 5 of 11 patients and reached up to 7 of 11, 64% at the latest time point. The neutrophil response was definitely the slowest and the most progressive. We had only 3 responders at 6 months, 27%. That increased to 64% eventually, reaching levels that are quite reasonable, between 1,000 up to 3,000 in some of them. And finally, the safety outcomes. So we have seen, as you can see, adverse events in most of them, AEs. But AEs that were possibly, probably, or definitely related to EPAG were much less common, and were generally mild, grade 1 or 2. Of those, iron deficiency stands out, as you can see here, and that's due to the well-established iron chelating properties of EPAG. So all patients, essentially 100% of them, except those that were red cell transfusion dependent, eventually required iron supplementation. Easy to take, but that's expected. We also see an elevation in LFTs, ALT, AST, bilirubin quite frequently, approximately 50% of our patients, but they're also generally mild. Never led to permanent liver dysfunction and never required discontinuation of treatment in any of them. We're working with children, but it's not all, obviously. Rainbow, lollipop, and sunshine, we do see serious adverse event SAEs. We've documented SAEs in 5 of our patients. 3 of them were unequivocally related to the underlying disease. So these 3 occurred in patients who had no response or no blood response, and one had a sepsis, one had hemorrhage, and unfortunately both died. The other 2 we classified as possibly related to EPAG. In one patient, we observed monosomy 7 in 16 of 20 metaphases at approximately 12 months of treatment. We had no evidence of dysplasia at that time, no increased myeloblast. In another more recent patient, we observed an acute myeloid leukemia, AML, that occurred also around 12 months of treatment. Both cases have been referred to outside institution for transplant and are reportedly doing well. And that's usually where people start throwing stones at me. But I'd like to remind everyone that this is a disease where acute myeloid leukemia abnormalities in cytogenetics are common. So even though we see those 2 cases there, it does not necessarily indicate that there's a direct link to EPAG, even though I cannot formally exclude it. I put this reference at the bottom here, which was published by Dr. Alter some time ago, reporting an incidence of AML in FA at approximately 7.2%. None of them were obviously treated with EPAG, which is very similar to what we see in our cohort so far. So in summary, I think these preclinical and relatively long-term clinical data suggest that EPAG certainly has a potential to stand as a new drug therapy for Fanconi anemia. Looking ahead, we're planning to expand our current cohort up to 25 subjects. We're also getting some interesting data in terms of increasing dosage, which seems to lead to a more robust and perhaps a fastest response. And I can talk about this later. But for me, the most exciting is perhaps the bottom part, where we could include this treatment prior to ex vivo or in vivo gene therapy to increase cell dose for genetic treatment. And we have several pretty exciting projects that are ongoing along those lines in my lab. So this is just to acknowledge everyone, and a special call to Brittany Colling, who's our lead research nurse, point of contact, all our collaborators at the NIH, our funding sources, and obviously our patients and families. Thank you very much.
Thank you, Dr. Larochelle. I would like to invite Dr. David Young, who will talk about medical therapies in Diamond-Blackfan anemia.
Okay. Well, thank you very much for introducing me, and it is my pleasure to talk to you today about non-transplant treatment options for Diamond-Blackfan anemia, or in other words, for something a little bit different from what we've been talking about most of the morning, and evening too at this point. These are my disclosures. And so hopefully most people here are aware, but I will just briefly discuss a little bit about Diamond-Blackfan anemia. As I mentioned, it is the first time we've actually discussed it today. And it is a inherited bone marrow failure syndrome characterized by the early childhood presentation of isolated macrocytic anemia with reticulocytopenia and bone marrow erythroid hypoplasia. DBA is an inherited condition, and as such, genetic testing can be informative in confirming the diagnosis, but nonetheless, because of a variety of reasons, it remains a clinical diagnosis based upon presentation and requires consideration of a broad differential diagnosis. DBA can present in a variety of ways, from a subtle anemia that's not recognized until retrospectively in adulthood to a very severe, life-threatening fetal hydrops. In addition to anemia, some patients will have cardiac, skeletal, facial, or other congenital abnormalities. And of course, it is also a cancer predisposition syndrome. There is an increased risk of myelodysplastic syndrome, as well as myeloid leukemia. And there's also an increased risk of gastrointestinal cancers, sarcomas, and even breast cancer. The reason for these really is unknown at this point. Yet the most significant life-threatening complication for many patients is the transfusion-related iron overload, which can cause some very serious health issues, especially cardiac and liver related, and can also complicate later treatments, especially bone marrow transplant. Like Fanconi anemia and the telomere biology disorders, DBA is a multigenic disorder, and it has been linked to over 20 genes. In classic DBA, when a gene can be identified, it is one of the myriad of genes involved in ribosome biogenesis. But in a subset of patients, the pathogenic mutation is a non-ribosomal gene. Interestingly, an underlying commonality linking all these seemingly disparate genes is iron homeostasis, which offers a little bit of an insight into how the disease comes about, as well as possible ways of treating it. During a late erythroid differentiation, there's a rapid hemoglobinization of the red blood cell that requires a careful balance of heme synthesis, which on the one hand is an enzymatic process, and on the other hand is the globin translation by the ribosomes. In DBA, there is a ribosomal haploinsufficiency, which prevents the efficient production of globin. And as there is no feedback mechanism within the enzymatic process, this leads to an excess of free heme, which is toxic not only to the developing cell, but also the central macrophage of the associated erythroblastic island, and even the adjacent hematopoietic cells. In non-classical DBA, where there isn't a ribosomal mutation, but a different mutation, a similar effect usually occurs due to defects in heme export machinery, which leads to an accumulation of free heme that wasn't bound by normal globin production. The mainstay therapy for DBA is steroids, and approximately 80% of patients will at least initially respond to steroids. But by late childhood, almost half of these patients will either relapse or become intolerant to steroids due to side effects or the inability to wean to a lower dose. As a result, at least a third or more of patients will require chronic transfusion therapy, most for life. Because of the side effects of both of these therapies, alternative therapies have long been sought. Yet despite anecdotal reports of responses to various growth factors, to immunosuppressants, and other agents, many clinical trials have failed to find a broadly effective therapy. Even the most promising agents, which would be cyclosporin, which we don't understand any reason why it works, leucine, or metoclopramide, have only shown modest or even inconsistent results at best, and so a lot of these trials and search is ongoing. Recently, we completed our own trial of eltrombopag in DBA, based upon the idea that eltrombopag is a potent chelator of iron, as well as its ability to stimulate and support the hematopoietic stem cell environment in general. We undertook a treatment of 15 subjects with a variety of mutations. This trial was initially based upon an indexed patient who had a very robust response to eltrombopag and had a known DBA mutation in the RPS19 gene. However, despite those promising results in that patient, we only experienced one additional non-robust response in our cohort. There weren't any safety concerns that were identified. There were only a handful of SAEs, and all of them were easily manageable. But the majority of the patients on the trial experienced thrombocytosis requiring multiple dose modifications. As a result, most of the subjects received significantly less drug than planned. Indeed, almost half the patients received 75% or less of the planned dose, and some received even less than half. As a result of this, certainly in addition to other aspects of DBA biology, which we probably still don't understand, this all likely caused the low response rate in this trial. Eltrombopag does appear to be safe in DBA, and it may still be an option when other modalities have failed, especially if a transplant-sparing option is sought. But the trial itself did not reach the futility threshold at interim analysis and has since been closed. The results were actually recently published just last week in the British Journal of Hematology. Looking sort of to the future, there is, of course, the question of, is gene therapy possible? This is, of course, a genetic disorder. And we know that even in something like eltrombopag, which we had hopes for, would not be, of course, curative because of the underlying fact that this is a genetic disorder. And so that reason, DBA is an attractive target for gene therapy, and preclinical data suggests that the hematopoietic stem cells may be less fit in DBA, allowing edited cells to overtake them within the niche. However, current gene therapy techniques must contend with the fact that DBA is a highly polygenic disorder with over 1,500 unique mutations spanning no less than 25 genes, and almost a third of patients will have no identified mutation despite clearly having the clinical diagnosis of DBA. In addition, it is yet unknown what amount of correction is needed to eliminate the DBA phenotype completely from patients who have it, so whether or not a complete replacement is necessary or just a smaller proportion, as we see in diseases such as sickle cell. Nonetheless, two general approaches are currently being pursued. First is the individualized approach, where we target the affected gene either through direct repair of the defect or by supplementation with a transgene. And the alternative is a more universal approach, whereby a transgene is introduced to bypass the DBA phenotype, regardless of the specific mutation involved. And a promising candidate for this has been GATA1. I would briefly like to mention that although a lot of these gene therapies are still in clinical development, there is one trial coming through my colleagues Senthil Bufalin and Mitchell Weiss at St. Jude, who have developed an xenogenetic model of RPS19 mutated DBA, which they have shown that they can then correct using a lentiviral system. And they are currently conducting preclinical assessments and hope to have a trial open towards the end of this year. However, given that gene therapy is not yet in clinical trials, and recognizing the fact that many patients will not be candidates for such studies, especially patients who don't have RPS19 mutated diseases, or who don't have a known mutation, or have other reasons for not being eligible for gene therapies, we are still continuing to look for medical treatments for DBA. Inspired by the work of Dr. Janice Abkwitz and others, we have turned our attention directly to targeting the heme synthesis pathway, going back to the idea of iron and heme imbalance being a part of the disorder. Bitopertin is a small molecule that selectively inhibits the glycine uptake by developing erythrocytes. This is a key substrate of the rate-limiting step in heme synthesis, and thus bitopertin slows the production of potentially toxic free heme. This approach has already shown promise in clinical trials of erythropoietic protoporphyria, and has also been promising also within the some in vitro models of DBA. The idea is that by slowing production of heme, the production of globin is then able to catch up, and the balance is then restored between the free heme and the globin in these cells. And so, inspired by a lot of this work and inspired by some of the results that Dr. Abkwitz herself has been getting in mouse models as well as in human models, we have set out to determine whether bitopertin can improve erythropoiesis in DBA patients. Our study has several goals. The primary goal is, of course, to determine the effectiveness of bitopertin in DBA. Looking at the response rate is informed by either increases in anemia or improvements in anemia or decreases in transfusion rates. We also wish to assess the safety and tolerability of bitopertin in DBA. And then we also plan to study the long-term treatment of DBA with bitopertin through an extended access phase, reflecting the fact that we expect that patients who do respond to bitopertin will likely require long-term treatment with the compound, as this is a genetic disease. Even though bitopertin is relatively novel within the area of hematology, it actually has a well-established clinical profile. In a study of over 4,000 psychiatric patients and healthy subjects, bitopertin was readily absorbed. It was tolerated over long-term exposures and had no significant safety concerns, even at high doses well beyond what we plan to use. Pharmacodynamics show that bitopertin inhibits glycine uptake at doses as low as 10 milligrams daily, and this effect plateaus at approximately 60 milligrams daily. And importantly, bitopertin does not interact with most common medications, particularly chelators that our patients are often on. And for those reasons, we have designed a dose escalation trial for up to 60 milligrams with a plan to treat at a stable dose for at least 3 months. And this is the overall study design, consisting of enrollment, dose escalation, maintenance, response assessment, and the possible extension phase. The subjects will come to the NIH twice during enrollment and at the 8-month primary endpoint for a complete evaluation, including labs, examination, and bone marrow testing. And then after enrollment, each patient will undergo an individual dose escalation from 5 milligrams up to 60 milligrams daily. They'll be monitored for toxicity and effect, and the dose titration will be either to the minimum effective dose, the maximum tolerated dose, or 60 milligrams, the study maximum dose, whichever is reached first. Regardless of the final dose, there will then be a maintenance phase for 3 months to ensure that all patients receive at least 4 months of exposure at that final dose. And it's important to note that during the escalation and maintenance, there will be monthly evaluations, but all laboratory testing can be done at home, and all care, including medications and transfusions, will be monitored by the local, or will be managed by the local team. And then after 8 months, patients will then undergo an evaluation back at the NIH for response and safety. The primary response criteria are shown here, and they examine changes in the hemoglobin as well as transfusion rates. And we will be looking both at response as well as a robust response, with the robust response being effectively transfusion independence. And then patients with any level of response, whether robust or not, will be offered the opportunity to continue for an additional 3 years. Non-responding patients will come off of the drug at that point. Many DBA patients do not have identified mutations, therefore inclusion in this trial will be primarily by clinical diagnosis, which is macrocytic anemia, reticulocytopenia, and a paucity of bone marrow precursors, presenting on or before the 3rd year of life. We recognize that a small but significant fraction of patients initially present later in life, and they are also eligible for participation if a causative mutation can be identified. Patients must have had clinically significant anemia and either failed prior steroid therapy or have relapsed or be intolerant to steroids. This study is open to patients 18 years or older, but for regulatory reasons, bitopertin can only be shipped within the United States. We are working on ways to enroll patients who are from neighboring Mexico or Canada. We plan to initially enroll 15 eligible patients, and if we observe a response in 2 or more patients, we will expand to enroll an additional 10 patients for a total of 25. A frequent question that we do get is whether or not chelation is allowed, and patients will certainly be allowed on chelation while on study. However, the treatment must be started before enrollment, and new chelation therapy is not allowed while on study to avoid confounding. With that, I'm pleased to announce that the study with bitopertin is open for enrollment. We have actually enrolled 4 patients, have 3 currently on drug, although we haven't yet reached the endpoint for any of them yet. You can find more information at the Search the Study website shown here, and I do also have information cards for anybody who might be interested in them. And I thank you for your attention.
I know I'm standing between you and a glass of wine. So, per Dr. Young's instructions, 5 minutes for questions and discussion. Start with Dr. Young.
Right behind you.
So I was perhaps hard on the transplanters, and this question is to Dr. Oved. So I really love the idea of your testing anti-gamma interferon. It's taken a long time, and I did check. It was back in 1985 that we published, in PNAS and elsewhere, the potential role of gamma interferon. But I'm worried about your trial, because you're going to be taking kids and waiting 6 weeks, some of them severely neutropenic, with an experimental therapy and no other treatment. I mean, it's obviously gone through IRBs, but I'm a little uncomfortable. And I just have to say that we take a lot of care, as in the preemptive study that Bhavisha's doing, in which we treat patients who can't get to ATG with cyclosporin and eltrombopag. And it doesn't take us usually 6 weeks to get a full workup, and especially in a severely neutropenic patient, what are you going to wait on? You've got a negative Fanconi anemia, you've got normal telomere length. What's the likelihood of you picking up something that's going to change your treatment?
So that did come up as a discussion as we were making the trial. We actually looked at our center's median time to curative therapy, and it was a little bit longer than that. And so we do have written in the protocol that if a patient is ready to go and that medically decided that they need to get treatment, that right then and there they can go straight on to therapy. So we're not holding back therapy from anyone that should get it.
Okay. I'm really excited to see what you get given.
There is also a biomarker.
No.
Did you say to test the biomarker?
So we're going to check.
To predict the response.
So yes, we're going to check CXCL9. The problem with CXCL9, though, in some of these disorders is that sometimes it's sequestered in the organ, or let's say in the marrow itself, and we don't have a validated way to check that biomarker. So we're going to check it on a research basis in the marrow. We have done some preliminary work in newly diagnosed aplastic anemia patients, and many of them do have an elevated CXCL9 3 to 4 times above the upper limit of normal, at least at our center. So interferon gamma is interesting in that the half-life of the gamma itself is very short and very hard to capture in the peripheral blood, and so that's why we use CXCL9 as the downstream monokine of activated gamma as a biomarker for gamma activation.
So you would treat positive.
So we're gonna treat all comers that are newly diagnosed, but we're gonna collect the biomarkers to see if the biomarker can be used as a predictive biomarker.
Hello. Yes, I have a question for Dr. Durrani. When you analyzed the number of JAK inhibitors, and several of them did not seem to work at the dose that you tested, and there was no effect on lymphocytes, right? How did you measure effectiveness, that you delivered the effective dose and you measured the appropriate on-site effect to confirm that the effective dose was delivered in order to see the response?
We have not performed that for drugs other than ruxolitinib. I think we're still in the phase of exploring, and we're assessing which ones to look for. But the point is, like, we agree with this, like, we have to check that before we have any consensus.
But you're right. I mean, it's actually extremely expensive or impossible to measure the drug levels and getting the drug into the animals. But the way the experiments are done is maximal doses are given. That's all you can say. Maximal doses that you can get into the animal by gavage, or if there's their food can be. I'm having my drink already. And I think everybody else should go out and get a drink now. Are we good?
There's one more question.
Sorry, Pedro.
Last question, Pedro.
Thank you very much. It's a very quick and objective question to Phil. Well, thank you very much for addressing an important question that is for algorithm-less patients that are not eligible to immunosuppression. But for this fragile population, I was quite intrigued by the choice of initial dose of cyclosporin of 10 milligrams per kilogram per day. And I wondered about kidney toxicity and the escalation of dosing.
So, yeah, that was especially, so the reason we started at 10 is because we were not going to give ATG. So we wanted to try to give as much immunosuppression as possible, at least in the beginning. There's some data to suggest that getting therapeutic levels early on might be important in this patient population. So we wanted to make sure that we had therapeutic levels in the first 4 weeks with eltrombopag, rather than going slowly and they reach therapeutic levels by week 6 or 8. So you could de-escalate very quickly after 2-3 days, given if the levels were high. So that was the reason. There was some pushback by some investigators saying that's too much of a high dose, I don't feel comfortable. But you could pull back after a few days if the levels were high, and the dose, the probably correct dose is 6 milligrams per kilo twice a day to get to 2 to 400. But that was the reason. There's no ETG. We're concerned about we're not going to give sufficient immunosuppression to this patient population. So that was kind of the idea. But
Thank you, everyone.